Good afternoon, everyone. Thank you, Chandak sir, for giving us this opportunity to share some work about OARM. And I just would like to start with OARM is the bigger brother of CARM. If you connect two C's, it becomes a O. And ultimately, we have all evolved from radiography to CARM, and now we are using this in the recent time about in spine surgery. When such patient comes to the clinic, a very severe deformity, a congenital deformity, then we always think, what should I do? And why the patient is come so late? Should I deny the surgery or what? All these are the unsaid questions in the mind because they are challenging cases, and we always think how the spine surgery is evolved. If you realize that the spine surgery is evolved with the advent of CARM and MRI in the late 90s, we can say 20th century, late 20th century, and now we have moved on to the OARM, the latest additional advantage of OARM I will be speaking about, and I'll just brief about how does OARM work in the operation theater in this small video.
The OARM surgical 3D imaging system allows neurosurgeons and orthopedic spine surgeons to view highly detailed, real-time images of the spine during surgery. The 3D images are displayed on a large monitor, allowing the surgeon to see exactly where to place surgical instruments and implants while carefully maneuvering around spinal nerves and nearby organs.
And this is how the OARM works in the operation theater, though it's a very bulky looking machine, but it's very easy to maneuver in the theater. And wherever we found some difficulties, and now we are realizing these are the challenges which we can really deal in a good way with OARM, mainly in difficult scoliosis, difficult spinal tumor surgeries, difficult revisions, cervical pedicle screws we have started doing. And this is where the advantage, because precision, accuracy and safety is the main thing. And OARM works on the principle of CT scan. It's like a CT scanner, but the amount of scan is very, very minimal. It's 13 seconds they take for the patient, and that's it. There is no other moment which occurs during the surgery. And we have the assets, tilt, navigation along with it, which gives us all the additional advantages. I'll just brief about the cases. And this is a 10-year-old boy, comes with severe kyphoscoliosis, progressive deformity, worsening, and neurology was almost paraparetic. He was becoming paraplegic, and we were in puzzle. And how do we manage this case? Young boy, 9.5, 10 years old. And this is where the OARM really helped us. And this is the reference point which gives us the idea. And for putting the pedicle screw, we don't have to, you can go in exact where you want to, 100% accuracy in even difficult, complex, deformed pedicles. You're not breaching medial wall towards the cord. You're not going lateral, inferior. You are going exactly. You need exact understanding of the anatomy. Ultimately, it is surgeon who has got his brain to be there along with the OARM. It's not that OARM will work for you. You have to use your ideas along with this, and this really works like wonders. If you see in these small pedicles, we are going through the pedicles, we really managed, we can measure the length of the screw exact, and we really can maneuver it very well. If you see, these are the intraoperative things which we can adjust, and then there are every instrument you can place. You can have a starter, you can have a probe, you can have tab, you can have a pedicle screw mounted on the navigation, and it gives you an exact feel. You can do osteotomies under this OARM, and this is what the deformity was, and we were lucky to get a very good almost 70 degrees correction in this 125 degree thoracic kyphosis.
We are doing the recording of the post-op X-ray on the OARM, and this is really showing us exact placement of the screws and significant correction in this very severe congenital kyphoscoliosis.
You're matured from doing freehand, and therefore it becomes easy for us to do it. And this is actual what we are doing it in the theater. It hardly takes few seconds for this to do
I want to see the lateral please now.
You don't have to move the image. You can see the APN lateral. You can see the 2D image first. Then you can go for the 3D, and that's it. Once you document, then life becomes really easy. You can just check with the
the wonderful technology.
And the arm is out of the, and you're doing the job. Maneuvering with the referencing with the nav locks. And you're just checking it directly while putting this probe before and that is there in front of you.
I think we are planning for.
So all these are the big advantages for spine for sure, because you are really worried. If you see, I'm putting the screw and I'm exactly parallel to the ground, but I'm very comfortably doing very less stress. Otherwise, there used to be a lot of panic moments, whether there is a breach and it is going towards medial side, cord, I'm not too sure. So all these things are a big advantage. Again, I'll just talk about 1-2 cases. And like this is a case of 16-year-old boy, difficulty to walk. He comes with almost paraparesis, and there was a large tumor at D8, if you see, and it looks like fluid filled levels. It was a ABC, and you can get an intraoperative image, how much tumor you resected. You don't have to think, you don't have to go back and again do the CT scan after the surgery. You can check it on table, and life becomes really easy in these kind of difficult ones where there is severe compression, anterior plus posterior surgery. We can do it through the posterior approach, and OAM really is of a great help. And this, you can localize the exact tumor, you can take out complete wide resection of the tumor can be done. You can check it on table. This is a big advantage in spine tumor surgeries, which we never had it before. And I will not go into the steps because of the time constraint, but this is what we can really get it during an intra-operative, and this is what the image we get. We could feel up the complete anterior segment with the graft. And these are the certain interesting cases where we have the cervical pedicle screw, started doing cervical pedicle screw in a high angular cervical deformity with myelopathy. If you see the significant deformation with myelopathy, we could put cervical pedicle screws of the PAR screw in cervical spine. And really life becomes very comfortable, because you are everything you are seeing the vertebral artery, you are seeing the cord, and it becomes, the life becomes really easy. I think this is definitely going to be a game changer in future, and for safety of the patient, this is a very useful tool. And we are learning with this. Now we are talking about it because we have done a lot of cases in recent time. And it's a multiplanar, it's a 360 degrees imaging. We can exactly see what you really want. And I think this is going to be there as we used to use CARM in future. I'm sure they must be working a lot on orthopedic appliances of this, and in near future we'll see a big sea change in all the surgeries. For spine, I am really happy to use this, and in revisions, in osteoporotic or in infective spine, where there is very soft tissue, soft bone. In osteoporosis, you don't breach a pedicle, you go exactly and you place the screws exactly the way you want. That's the beauty of it. In revision spines, you don't have to think much, because you are directly hitting the pedicle, you are checking it, and you are putting the screws. You can minimize the levels by doing the OARM navigated surgery. I think long learning curve, but it is definitely there, and it is in few centers in the world. We are lucky to have it with us, and hopefully we share our better experiences in the times to come. Thank you everyone for being there and giving us this opportunity to share our work.